the theme for this conference was orthopedic excellence through technology. And I was invited to talk about the use of navigation. So, what is navigation? All of us know that anytime we go out in our car, we don't go out without Google Maps anymore, right? We want to know what's the fastest way to get there. We want to know where the traffic is. We want to know everything about our route. So why not do the same thing when we are embarking on an even more important journey, which is a surgical procedure? So the process or activity of accurately figuring out one's position and then planning and following the route is what is the definition of navigation. So the important things are accuracy, and it still needs planning, and then you still have to execute. So those are the three things that are important from a navigation perspective. And hopefully, with all of those, you get better outcomes. So the basic steps, which most of you are familiar with already, are number one, this is an image-based procedure. So you need some sort of image, whether it's a CT, MR, or a biplanar or triplanar fluoro. Then you need to register the patient. I typically use the Medtronic Stealth, but there are many, many, many different systems out there. So we use a rigidly mounted frame, but you can use surface tracking as well. And then you track your surgical tools. And as we shall see further, you can combine that with more technology, which is robotics, just like we saw in the anesthesia talk. I think that is the stuff that is definitely coming in the pipeline. So we'll go through a few examples. This is what we kind of started with, because where do we really need navigation? We need navigation where we really need to be precise, where we need to be accurate. So where we need to minimize collateral damage. The physeal bar resection is a very standard pediatric procedure where we need all of these things. So this is an 11-year-old with a Salter-Harris 4 medial malleolar fracture 3 years prior to presentation. Develops a physeal bar, comes in with a varus and a recurvatum deformity and shortening, and you can see the asymmetric growth arrest lines pointing to where the physeal bar is. And then you get an MRI to map out the bar, and then we basically use navigation. So you put the tracking frame on, away from where you need to operate so that there's unimpeded vision in between the tracker and the frame. Then you get images. We use the O-arm, but again, like I said, there are various different ways of doing it. The computer processes the images, and then you register the instruments and you operate. It's as simple as that. So here we are, through a little tiny incision, you plan on the direction and the depth, and you go in, and it's done. It's as simple as that. So there we are, pre and post, taking out the bar and not much else off the physis, because we want that remaining physis to grow. And then you put in your interposition material there to minimize chances of recurrence. So basic principles remain the same. This is not a new procedure. This is just a tool to help you accomplish the goals that you've already set out. You want to resect the bar, which is what the navigation helps with. You want to correct the malalignment. So he had more than a 20-degree varus deformity, so I did an acute osteotomy to correct the alignment. You want to maintain that correction, and then you want to deal with the limb length discrepancy, right? So those principles remain the same irrespective. There's another example. This is a 7-year-old with a central bar in the distal radius. And again, you would have normally gone in through either a metaphyseal osteotomy and gone in into the center, or you could have come in with this, with navigation. And you can see pre and post resection. And here we are about a year and a bit later, and you can see that the morphology of the distal radial physis compared to immediate post-op is better, and the radius is keeping up with growth. What will happen over time, only time will tell. But at least in the short term, we've managed to get away with this. Another area which we've explored is talocalcaneal coalitions. And the two most common complications of talocalcaneal coalition resection are either you don't take enough bone or you take too much bone causing instability. Scott Mubarak has shown us that if you don't do an intra-op CT, then the chances of you not taking out enough bone are 4 times as high. So we decided to take it to the next level and say, okay, we'll get our intra-op CT, but why not use navigation to help with avoiding complications like this? So here we are. You get real-time feedback as you're doing your operation. You can see exactly where your burr is going in, and then you confirm at the end. So again, this is just a tool to accomplish your goals. Because you still, at the end of it, are going to do everything else that you would otherwise. And you still want to check and make sure that your joint is all the way open and you have maintained or restored your subtalar motion. So those things don't change. Principles do not change. And obviously, compared to a traditional with navigation, certainly in many instances, not in every one, but in many instances, you can go with less invasive surgery. So hopefully give you better outcomes. So there's her. She had bilateral talocalcaneal coalitions. We resected both of them, and she's doing quite well. So this is our current experience with talocalcaneal coalitions. We've done 11 of them so far, and the navigation does add a little bit of time. So we've added about 18 minutes to our procedure. So we looked at the ones that we had done without navigation versus the ones with navigation. It does add a little bit of time, but certainly some of this is a learning curve. As I go through these more and more, it gets quicker and quicker. So at some point, hopefully, we will at least break even. We haven't had any technical issues. We've been able to resect every single one of them completely. We did have one reossification, so it doesn't necessarily avoid the other complications, right? No instability in any of them. We had improved range of motion, and just 2 of the 11 had some mild residual pain, but the follow-up is short. Now moving on to the tumor side of things. So this is an 11-year-old that came in with right hip pain, limited range of motion. CT showed a sclerotic area right by the physis in the anterior portion of the femoral head. We asked our interventional radiologists if they could get in there, and they said, well, it's too much bone, we don't have the right instruments. So I was like, okay, all right, we'll do it ourselves then. So we used navigation, got our guide wire in, put a cannulated needle right over top of it, and there we are, pre and post, taking out exactly what we needed to take out and not anything else. And that was a successful biopsy. Sometimes you can use it to salvage other things as well. So this is a standard osteoid osteoma, nothing exciting about it, very clear. You can see the nidus in the anterior femoral neck. Sandeep will probably argue that this you can do very easily without navigation, and I would agree with him. She had an attempted radiofrequency ablation as the first step because that is what we usually do. And as you can see, the needle wasn't quite where it needed to be. So 2 months later, there she is with persistent pain. And the mother obviously did not want another RFA procedure. So we went in through a little incision. And here again, you can see exactly how deep you need to go. And you can confirm that once you're done. The interesting thing was when you compare the radiation doses, you're looking at the dose area product, which is the dose per unit area that is absorbed by the body. This is from her CT-guided ablation. You can see that's far, far higher compared to what we had in the operating room. So this is something that we need to revisit and start thinking about as we go further. I've also used it for benign bone lesions. So this is a recurrent chondroblastoma in the posterior portion of the humeral head. And it's a little bit of a harder place to get into, so we use navigation to help with our curettage and drilling. So it does help reaching things in more complicated locations. But the real value of navigation is in the pelvis. We know there are several studies now that show that we are notoriously inaccurate when it comes to the pelvis. Even the well-experienced surgeons really don't quite get what they think they're getting. So if you look at the papers out of the UK, this is Rob Grimer's group. They basically looked at iliosacral tumors, and they found that navigation helped, number one, no intralesional resections, less blood loss, less OR time, and also less foot drop in these people. So certainly this is having a beneficial effect. People have started doing this for extremity tumors as well, so it helps improve your reconstruction with length matching as well as rotational stability or rotational alignment. This is a patient of mine, 11-year-old with a non-metastatic Ewing's, large tumor, goes all the way up to almost up to the SI joint, so he gets chemotherapy, which is standard. And then we go in with navigation. I typically will put in guide wires, which are easy to navigate, and then start with a saw and finish up with osteotomes. And here we are. You can see we are able to preserve the notch. We are able to preserve the SI joint. No need for any reconstruction. So advantages, it certainly improves our accuracy and precision. It also helps improve safety by limiting collateral damage. It may help save OR time in certain situations. And it is definitely better for margins, especially in the pelvis. And hopefully all of this will translate to better oncologic results and also better functional results. The obvious disadvantages are cost, radiation, and overdependence. You don't want to be this person who's navigating very safely into the tree. Remember, it is just another tool. It doesn't replace any of your other surgical acumen. It does provide real-time feedback. It's accurate, and it is useful in multiple situations. The bottom line is it makes a good surgeon better. I don't know if it's going to make my son Albert Einstein, but it certainly will help him part of the way there. Thank you.